Next up, we have Dr. Jeff Borgia, who's director at the Rush University Cancer Center Biorepository, also director of the Rush Biomarker Development Core. He's an associate professor in the departments of Cell and Molecular Medicine and Pathology at Rush University Medical Center. His PhD was in biochemistry at the University of Minnesota, and then he subsequently did 2 postdoctoral fellowships. He currently serves as the director of the Rush University Cancer Center Biorepository, where he oversees the collection and annotation of patient specimens to support translational research projects and clinical trials that are ongoing at Rush. In the Rush Biomarker Development Core Facility, he provides state-of-the-art services aimed at discovery and development of novel biomarkers for diagnostic applications, ranging from early cancer detection to personalized treatment selection for patients. His research program focuses on the development of novel diagnostic tests based on omic-level profiling of patient specimens and mechanism for pathophysiology. His talk today is the development of custom Immunobead assays for Neoantigen-Associated autoantibodies to prognosticate response to immunotherapy in advanced lung cancer.
Apparently I need to cut down a little bit on my intro submission, because that was pretty long. I thought you guys were burying me or something. Anyway. Seemed longer. But maybe it's because it was me and I'm uncomfortable with it. Anyway, thank you everyone for coming today, and the organizers for inviting me here. This first set of slides, the first part of the talk, I'm going to kind of skip through pretty quickly. A lot of the information was already covered by previous speakers, and I really would like to kind of get to the meat of the talk, which is more of the assay development part. For these first few slides, I'm just going to focus on 2 to 3 points. The first one being lung cancer is by far the most deadly cancer out there. 1 in 4 patients dies from lung cancer, and if you look at the stats on the slides, for the most part, you can put together 2 or 3 other malignancy types and still not reach the levels that are die from lung cancer. It's not the most common one, though. It's like the number 2 common one. So it's just particularly aggressive, and there's not good treatments. With that, most patients are diagnosed with advanced stage disease, as shown in the right side of the slide here. And so depending on when you're diagnosed, that tends to indicate how you would be treated. Early stage patients, surgery, maybe some adjuvant treatment there. But for the advanced stage patients, really it's kind of a salvage therapy. We're trying to buy time. There is no cure for advanced stage lung cancer at this point. Most recently, immunotherapy have come on the scene, and it really has revolutionized how these patients are being treated. And this was covered in great detail in the earlier talks. Now, there's a whole range of checkpoint molecules that some are inhibitory, some are stimulatory for the immune system. And basically, the immune system can be hijacked of sorts by the tumor cells and by interrupting these various types of interactions. And so with that, PD-1, PD-L1 type complexes is one of these types of interactions that is inhibitory to the immune system, the T cells specifically. And if that receptor ligand binding happens, the T cell is switched off. And so what we want to do is interrupt that. We want to be able to stop that interaction. And so therapeutically, as also was said, there's monoclonal antibodies that will stop that interaction. And that's effective for a large variety of the patients. And from these, I'm just going to go quickly through a couple of clinical trials. From here, the top, the blue line for the progression-free survival on the left-hand side of the slide, those are patients being treated with immunotherapy versus chemotherapy in red. Very big difference in outcomes for those patients. On the right-hand side, this is another one, the same sort of idea, that with, and that's for overall survival. So with the immunotherapy, it's definitely an effective way to go, but not everybody receives benefit from it. So how do we select the patients that receive benefit from it? In the first scheme here on the far left, we have basically a scenario where we're throwing it to the population, 1 in 5 responds, and that's great. What would be even better is if we can predict who that 1 in 5 is, since immunotherapy is about $150,000 a year. If we can say, here's the one that's going to respond to it, and we hook them up with the right medications, meanwhile the other 4, we move on to some other type of salvage therapy that has chances of benefiting them. Furthermore, the best scenario is from a patient comes in, we can, based on either genetic or circulating profiles, be able to say, here's the therapy that's optimal for you. And so that's the goal. That's where we're trying to go. A couple different ways this has been done for immunotherapy so far. Up front has been, and the first one that they used was looking at immunohistochemistry of the patient's tumor, looking at PD-L1 expression. So the PD-1, PD-L1 complement is what we're trying to inhibit with this type of therapy. By seeing that there's good expression of PD-L1 on the tumor, you can see from the Kaplan-Meier that there's good stratification of the different groups, and indeed those that have higher PD-L1 levels have a better response rate to this type of therapy. However, that's not always true for 2 different reasons. One, it doesn't always have a correlation, and 2, there's biopsies involved in this. Whenever you have a biopsy that's giving you a diagnostic or a prognostic type information, where is that coming from? If you have a homogeneous tumor, it's not a problem because you're getting a snapshot of what's going on with that tumor. Most tumors, especially in advanced stage lung cancer, are not homogeneous. There's a lot of different heterogeneity within the tumor itself. Depending where you sample, you can get a different answer, as is shown on the slide here. So what we really want to do is get to another method that is a little bit more general that can kind of give us that sort of same information. So that was the first round that was used for kind of helping to stratify patients. The second one that came up was using tumor mutational burden. Basically, this is like looking at all the different somatic mutations in a patient and trying to determine, like, is there a certain threshold that if you get to, the patient's more likely to respond to immunotherapy. Indeed, there was. At 10 megabase pairs per, or 10 mutations per megabase pair is where that cutoff was set. On the right there is the results from the Checkmate 568 trial, and there is a big difference. And so, yes, TMB can help predict, but the problem with that is it's expensive, and more importantly, it takes about a month to get the answer back. If you have advanced stage lung cancer, the physician wants to treat that person as soon as possible. They don't want to wait a month to get an answer back. And so the quicker you can get a turnaround, the better. So what would be nicer than this is some assay that you can turn over in a matter of like a couple days or a week, similar to like in the old days when we were doing EGFR mutational testing. That took 2 to 3 days. So with this body of information, we came forward with a hypothesis that if TMB is in fact associated with outcome, then a certain amount of these mutations will result in a variant transcript. Those variant transcripts, a certain portion of those will be translated into a variant protein. Those variant proteins, once they make their way out and the immune system can see them, will be the subject of an immune response. We can develop assays against that immune response and potentially use that to help identify which patients are likely to respond to the immunotherapy. A couple different benefits for that, which we won't go through right now, but it's going to be really cheap and easy for us to do this through blood type assays. All right, so how do we do our discovery? Our discovery is pretty straightforward, actually. And so we use one of these protein arrays, basically. And so the technology on these have come way forward in the last few years, where now you can, as a service, or you can do it yourself if you want, they have 20 to 24,000, depending on which generation you're using, recombinant proteins arrayed out on a glass slide, similar to like in the expression microarray type ways, and you read them the same way. And so now you have a means that you can look for an autoantibody against a specific protein in high throughput, high density type arrays. So in essence, we come at these arrays and we run 2 of them at the same time. One for a group that we pool some sera from responders, another where we pool some sera from non-responders. Put it on, we use an anti-human antibody for those, which gives us a signal. We read those and then we informatically compare them. So we look for, there's 4 different types of signals as indicated here. Yeah, they have no signal, which no information. You're going to see antibodies or spots light up where there's autoantibodies in both groups. Those are of no use for what we're trying to do. There's some that are specific for the responders, and there's going to be some that are specific for the non-responders. Those are the ones we're interested in for assay development. This is a volcano plot kind of showing how some of those divide up. We ended up with approximately 120 or so different targets that were statistically significant, either on the responder or the non-responder side, and these became targets for us to develop assays for. So let's talk about assay development now. So these are the various steps. We just did the hard part, so the first part there, which is we identified some targets. Now we know what we're going after. Once you've identified those, and we're basically just based on a financial limitation, we're just going to develop like the first 20 or so into assays. And we're going to pick the most statistically significant ones to do that with, of course. We identified reagents, and now we're ready to go. So first step is we want to conjugate our analyte, or let me try that again. Conjugate our recombinant protein, which is a stand-in for our neoantigen. So this is what the transcript variant ends up in a protein variant that the cells are producing. This is the stand-in for that. And we're going to conjugate that onto the beads using pretty straightforward. This is in the Luminex cookbook. You can easily get this online. Very easy to do. And with that, we can just conjugate beads in different bead regions all day long. And so we developed 17 of these in total. Key to the success of this, and I can't stress this enough, fresh materials. That make sure you have fresh reagents for the EDC and the sulfo NHS. Everything is kept nice and dry. You'll have great success with this. And then also avoid any sort of primary amines in any of your buffers, because those will compete for your recombinant protein in the conjugation reaction. Now, with that, so now if we have a range of different beads that have been conjugated with different recombinant proteins, now what we want to do is see, well, did that work? And so the assay that we use for that is pretty straightforward, where we can commercially purchase antibodies against the recombinant protein that we just conjugated onto the surface. This is a stand-in, again, for what the patient's antibodies will be, what we're trying to measure ultimately. And so these these proteins that we want to measure all have polyclonal antibodies available. And again, we want to use polyclonal antibodies, not a monoclonal antibody, because we want to have that amplification, and we want to try to reproduce as much as possible the sort of clonality heterogeneity that we would see with patients. And so we would buy like a rabbit or a goat anti-target antibody, and with that, we'll come up with another species to be our detection antibody, and now we have an assay. And that's kind of what's shown in the top part here, where we have the assay with 3 different clones that recognizing the recombinant protein. With that, so now we look at a background level, which we don't put the antibody versus that with a 4 microgram per mil. And now we can go through the list of the different assays we made and look for differences between the background and the positive control, basically. And usually we like a threshold of at least of a MFI value of, say, 5,000 to 10,000 is like kind of the bottom of what we like to do for these assays. Once we have that, now we're ready to go on to the next step, which is really kind of evaluating how this went, and is there cross-reactivity, and what are some of the analytical performance characteristics. And so just to show you a couple of these, so these are, again, these are dilution curves of using the polyclonal antibody, where previously we used it at just the 4 microgram per mil, just as a yes-no positive control. Here we're actually developing a standard curve from that to kind of get an appreciation of the performance of this assay with that particular antibody across the range of concentrations. And then with that, how can we develop performance characteristics based on that? And then those performance characteristics, how do those compare when you have just an individual assay versus you put it in a multiplex? And so as you can see, there's some heterogeneity here between having it in a singleplex versus a multiplex. And some you lose your dynamic range a little bit, and some you actually gain a little bit of range, and it pulls out. So you really have to kind of see how it goes. Now, the thing you have to be careful of, this is using a a rabbit or a goat antibody. This is not the human antibody. And so these are just characteristic of what you would expect to see. If you wanted to see actually what you would be observing with the patients, you have to actually purify that antibody from the patients. And unfortunately, each patient develops a slightly different one, so each patient would need their own antibody, which is not feasible, so this is what we do. But to get an idea of if there's any differences with your population, you might want to think about isolating your polyclonal antibody from your patients at some point. Does that make sense? You can ask me a question later if not, I guess. Anyway, make sure you have enough points in here you can see the full curve, though, so that you can really get a good appreciation of what's going on. So now we want to look for cross-reactivity. So now we've seen that we can dilute it out and we can get a nice sigmoid curve. Now we want to see, are these beads interacting with each other? So there's a leave one out type protocol, which again is in the XMAP cookbook. And in essence, in this case, we're doing like a direct assay as opposed to a sandwich assay, so it's a little bit simpler forward. But we have the beads plexed together, and then you can run it a couple different ways, actually. One was a put one in versus a leave one out sort of approach. But basically, you want to see if an analyte's not there, you shouldn't have a signal for it. If you get a signal for it, you got a problem that you have to either separate one of the reagents out or come up with some combination that you don't have that sort of cross-reactivity. If you absolutely positively need those plex together, there's ways you can do workaround, trying different reagents, some blocking and stuff like that. But typically, if we see there's a problem, we'll separate that one out. So no point in trying to spend too much time trying to work on it. We'll separate that into a different plex, and we'll only do that so many times. On the right-hand side of the slide, you can see that going diagonal is where you'd expect, like, there's a signal for the one that it's supposed to be. So it's a two-dimensional figure where you're looking at different areas. And so what you're looking for here is if there's cross-reactivity, horizontally there will be it'll become more red. And so GAP-DH, for example, lights up pretty much with every other assay that's in the panel, so that one has to be separated. And there's certain thresholds that we set up, but if you look, like the VSIG10L has some signals in there too, and the BAT3. At some point we developed a threshold where we say, okay, everything above this line has too much cross-reactivity, we're separating those out. And what we came up with was a 13-plex, basically, that we're able to move forward with. So now we want to go through and start looking at some of the characteristics of this, which include accuracy, precision, sensitivity. I'm not going to go through each and every one of these, but I just wanted to kind of show a couple of these in the interest of time, which is the dynamic range of these assays is key. The idea here being that we want to really be able to measure clinically relevant levels with a reasonable amount of sample. We don't want to have to do these assays using milliliter volumes of samples. We like to do this with as least amount of sample as possible and be able to get good values on a population of patients. And so all of our assays, and so this is all of the 13-plex over each other, have pretty good ranges on them. And so this is the range here. I don't have the lower one, but it's like 3 nanograms per mil, I think it is, up to 16 micrograms per mil, which is a pretty good range. And so the range on these assays were pretty broad. We're trying to get to the point where we're understanding the full dynamic range for each of those assays right now. The reproducibility of these have been pretty well. So looking at the plate 1 versus plate 2, these are ones that were done in parallel, and we have good reproducibility in any given read, although that kind of fell off when we were looking between the different reads. And I suspect that's most likely the instrument as opposed to the assays. The way to get around that is, and we didn't have this in this assay, is there's standard beads that give you that you can include in every assay that you can use to maintain like a QC and QA on your instrument to show that, well, the instrument's performing okay or the instrument's not performing okay. So we didn't do that in this case, but that's my suspicion of what happened here. We'll reproduce this now that we've had a PM done last week, actually. Then the final part. So now at this point, we have the assays, we developed the assays, Analytically, we know that we have something in hand with some performance characteristics. Now we want to start deploying them clinically. So the first thing that we have to do is see, okay, and I mentioned before, we want to make sure that clinically the levels that we would be observing in the patient's sera are things that fall in the dynamic range of these assays. So step one, we get some patient sera and we dilute it up. And we do a dilution series. We titrate it out and see how does that profile look relative to one another. Is there a point where it saturates out? And so with each of these different ones, so for this particular one, we took 6 patients. And with the 6 patients, we were able to go across the various dilution factors that you're seeing there. And what we're looking for is to see at what point does this get in a range that we're well within the range of our assays, but we're not saturated out such that when it forms the top of the sigmoid, at that point, we're not going to get a good linear signal from the assays when we run them. And so this is with 6 patients, and we had reasonable MFI values with exception to the GBP2. But important concept here is this is 6 patients versus 135, so the GBP2 actually came into a reasonable number when we looked at an entire population. So it just so happened those 6 patients we selected before didn't have high levels of those antibodies, and that gave us kind of an erroneous sort of low level on those. So actually where we ended up, how do I go back? There's the back. We ended up with the 1 to the 100 dilution, which you wouldn't expect. You'd probably, looking at the 6 patients, probably say well, maybe 1 to 25 is what you should do, or maybe even try doing it more concentrated. But when we actually got in there with the 1 to 100, after reproducing this, it actually ended up being a good number for us to be right in the middle of our standard curves for most of these, which is where you want to be so that you have good range up and down for the measure the range of your population. Okay, so the assays developed. We're in the range of the assays. Next thing is there prognostic significance to these? Can we use these assays to help determine if a patient is likely to respond to a therapy or not? And so this is looking for progression. So with the, I probably should have told you this earlier. So with the advanced stage patients, they look for 2 things. How long from the time of diagnosis do they have before the disease starts progressing? And so that's used as an indicator of is this therapy working for you or not. The other thing they use is does this interrupt the natural history of the disease? That is, can we promote your survival, make that longer? And so the 100% mark going across, the red line, for example, those are patients that are carrying low levels of these of that antibody. So there's actually 2 different classes of these. So there's antibodies associated with responders and antibodies associated with non-responders. And so we're looking at these, so you want the red line. And so for the most part, we have 2 different ones, and for each of these you can see that there's high levels of some of these antibodies give you an improved outcome. And this is for progression survival, this is for your overall survival, and this is for, again, like time to the patient expires. And you can see that there's some of these high levels give you, like in the GLUL, in that one, low levels give you a poorer outcome versus a higher outcome, versus the GPP2, where the higher levels give you an improved outcome versus a lower outcome. So indeed, there's prognostic significance to some of these assays. Our next step now is we're basically going to try to combine those together into some optimized combination and then go forward with external validation. With the discovery of these markers, I think that has great potential using this platform specifically in order to allow us to really start first evaluating other patients' blood, both from Rush and from places around Chicago, but then rolling it out in some trials to see if in other institutions from around the nation we have similar sorts of performance. If that's true, then this might be something we would want to approach like a Pfizer or a Bristol Myers Squibb to see if they're interested in combining it with their agents in order to help in product selection. And that's pretty much the end of my talk. I want to thank the organizers again for inviting me. And then Imad has a poster. So most of this work here is Imad's work. And so if you have really nitty-gritty questions, he's the guy you need to ask. His poster is right over here. And I'd like to thank you for your attention today.
We have plenty of time for questions. Come on up.
Thank you for your nice presentation. My name is Venkat Venkateswaran from Tetracore, and I thought the test is, especially the patient sample, when you are measuring the antibody, it is a qualitative, whether the antibody is there or not. But whereas all your standardization that you have done and the titration curve and all are with the polyclonal antibodies, so how are you going to use that quantitative values with patient sample, and what does that dilution and concentrations or all those things are useful in making clinical evaluation?
Yeah, the answer is we're not. And so so those standard curves are based on the idea of, for the most part, a rabbit antibody against that. So how those levels would compare to that of a human patient, we don't know. And that's what I was kind of waving my hand at earlier in the talk, that if we really wanted to quantify these, we'd need to isolate some human clones that we would use in a standard curve. It's not out of the hand, that's very doable. It's just, I'm looking at this more of like, I'd rather have a panel of these different assays where we're really looking for a yes-no answer from a bunch of different ones. And using that binary assessment, or even you could have like a low, medium, high, but having like a negative threshold. In the earlier talks, we were talking about like cutoff values. Having like a cutoff value where a bulk of the population would give you a negative, and then above that there's medium and high or low, medium, high sorts of assessments. Using that going into a panel as opposed to an absolute quantitation of the level of an antibody. And I'm kind of looking at it more that way. I'm open to suggestions on this, though, because it's a little bit difficult, because there's really not a true quantitation with this, given because even patient to patient, there's going to be different clonality, and I don't know what you're going to do with that.
So I think one of the suggestion is, as the previous speaker that Dr. Siddharth Mohan was mentioning, once you develop all these assays, once you start doing is, especially even the plus or minus, and when you start testing more samples, you will have a nightmare of data processing, especially what this plus minus means and all those things. Probably it is the right time for you to look at the data analysis algorithm, what all these things mean. So probably start looking at that, and we may have some ideas later on we can discuss.
Yeah, no, I like that idea.
Thank you.
In addition, I mean, you can sit down, I guess, if you want. But this technology is like so adaptable that even for like we're talking about vaccines earlier, or he's back there now, we could use this to look for, is there an actual immune response to what you're vaccinating for? Because we could take his peptides, conjugate it onto beads, and basically just evaluate the patients before and after they received the inoculations. So
yeah, I think the vaccination, it is probably a lot more predictable in the sense, you expect the immune response. But whereas here in the patients, especially when you are looking at neoantigens, each patient, they respond differently. And
agreed. But what's interesting, though, is when you look at the DNA, so these so-called liquid biopsies, that's just a plus minus. They're just looking like, does they have the mutation, yes or no, too. And those increasingly are moving over from a tissue-based to a liquid-based sort of test. And so there's multiple companies that are coming up with these, like, 200-plex like DNA assays that they're measuring from, basically you get a tube of plasma and they will isolate all the nucleotides from that and then run next-gen sequencing on it. And, well, if they can do that and with the yes-no answer deliver some sort of answer, there's no reason we can't do it with antibodies.
I think it is very powerful. My only thing is, because you are going to look at the complete reactivity pattern, that pattern can really give you a very good estimate of what is happening. So then you should be able to handle the data analysis. It is not just getting the data out of the experiment.
I also like the idea of a combined DNA/protein Luminex assay for doing this
Thank you.
in one pot. Where's our engineers? So, yeah, there he is. All right.